Bismillahirrahmanirrahim. Assalamualaikum everyone. Today we will be starting with a new topic which is of dental cements. So let's look at the table of contents. So we'll be starting in the introduction. We will be looking at various definitions related to cements, then the classification of dental cements, the ideal properties or requirements of dental cements, the different setting reactions, the clinical application of cements, advantages and disadvantages. In the cements we will be covering will be zinc phosphate, silicate cements, polycarboxylate cements, glass ionomer cements, and the recent advances in dental cements. So if you look at the timeline of dental cements, they've been around since 1850, and the oldest being the silicophosphates, the zinc phosphates, and then the latest being the modifications of the glass ionomer cements and resin cements. So a few terminologies that are important to be discussed before proceeding. We'll be talking about basically in the topic in today's topic. Liner and bases. Basically, these are also cements, and these are placed between dentine and restoration. So they go underneath the filling to provide pulpal protection or pulpal response. So it depends upon the type of restorative material and extent and location of the preparation. So a cavity liner is a thin layer of cement used for the protection of pulp. Primarily, it is to provide a barrier to protect the dentine from residual reactants diffusing out of the restoration or from the oral fluids. So it serves as a protective measure against any kind of reactants. Also provides the initial electrical insulation and some thermal protection because the function is basically to act as an insulated agent underneath fillings that have high conductivity, for example amalgam. Some formulation may provide pulpal treatment. However, they have low mechanical strength and cannot resist the condensation forces. So their objective is not to provide any kind of mechanical barrier, and they just basically have a protective objective. And the film thickness of cavity liners is less than 0.25 millimeters. Examples of cavity liners are calcium hydroxide and low viscosity zinc oxide eugenol. Now these are all the cements that we will be discussing in the upcoming lectures. Then let's go on to the base. Now the base, as the name suggests, is a layer of insulating, sometimes medicated cements placed in the deep portion of preparation to protect the pulpal tissue from mechanical, thermal, irritation and chemical injury. So basically it functions as a protective barrier to mechanical and masticatory forces, thermal irritation and chemical injury. Provides thermal protection to pulp and to supplement mechanical support for the restoration by distributing local stresses from restoration across the underlying dentine surface. And as the name suggests, it's a base, so it's thicker in thickness. So it's thicker and it is applied in a thick layer to resist the condensation pressure and provide the insulating barrier. And it is usually more than 0.75 millimeters in thickness. Examples of bases are zinc oxide eugenol, zinc phosphates, and GICs, and these are applied in basically in thicker quantities. So this basically shows the base and the liner. As you can see, the base is thicker and the liner is thinner in comparison. Now then cavity varnishes. So these are natural gums or synthetic resin dissolved in an organic solvent. Film thickness is 2 to 5 microns and it forms a coating on the cavity surface by evaporating because it's dissolved in a solvent to prevent penetration of corrosion products from amalgam. Usually it is used underneath amalgam restorations in shallow cavities and it is applied onto the base and walls of the cavity. So copalite or 10% copal resin dissolved in ether, alcohol or acetone, which are volatile solvents, are usually used. And again, the function is just to seal the dentinal tubules against the corrosion products or the ions that may leach out from amalgam. Because it's applied in such thin layers and it does not have sufficient strength, it is not used to provide any kind of barrier against mechanical force. Then another term, the luting agent. So we've discussed the liners, the bases, and the varnishes. Now the next are the luting agents. So luting basically means to attach or cement that to the tooth. So, or any kind of cement used to attach or cement the indirect restorations, which may be crown, bridges, inlays, onlays to the prepared teeth, are basically called luting agents. As you can see from the picture, the first picture on the left shows a bridge, and that is luted onto the prepared teeth. And then the second diagram shows a crown that is basically luted upon to the prepared tooth. And the film thickness is 0.25 millimeters, and the viscosity should be low so that the cement or luting agent is able to flow into a continuous film and lute or cement the prosthesis onto the prepared tooth. Now the uses of dental cements broadly for pulpal protection, as we discussed in the earlier slide, as a liner, base or varnish, for luting or cementation of crowns, inlays, onlays, veneers, orthodontic brackets. For restorations, they may be temporary or permanent, and in case of surgical dressing or periodontal surgeries. Chemical protection, electrical protection, thermal protection, and mechanical protection. So if look at an amalgam filling, so the pulpal protection, basically if we are giving a base and a liner, the chemical protection is from the corrosion products or the components like mercury or other ions that are leaching out. Electrical protection, obviously because amalgam is a conductor, so or in case of an opposing metallic filling, if there is any galvanism, so the pulp has to be protected, otherwise the patient will feel sharp current like pain. Then mechanical protection, obviously because of the high masticatory forces that are being exerted on the restoration. And then pulpal medication, for example, if a liner is given which has some sort of medicinal or reparative tendency, so that provides a pulpal medication. And then thermal protection, again it's similar to electrical protection, because amalgam or metallic restoration, because it is a conductor, so we need an insulating base underneath it so that it does not transmit uh, uh, temperature changes to the pulp and hence bring about sensitivity or pain. So the general properties of dental cements. An important terminology, the film thickness. As we saw, basically the different film thicknesses, they vary according to the application. They're different for bases, they're different for liners, they're different for luting agents. A thinner film and less viscous is more advantageous for luting, and that depends on various factors. Obviously, the particle size and the powder liquid ratio, amount of force applied during seating of the prosthesis, direction in which that force is applied, and the design and the fit of the prosthesis. So, an acceptable thickness of 50 microns is recommended. Biological properties of cements, pH should be neutral ideally, but most of the cements are acidic, but they lose their acidity gradually with time as the setting reaction takes place. The acidity or the pH basically comes down almost close to neutral, so that's not an issue. Pulpal response, if it is there, should be mild to moderate. Pulpal protection, it should not irritate the pulp, so it is advised not to use thin mixes. Now let's look at the ideal properties or requirements of the dental cements. So ideally they should have the same translucency as tooth structure, so they should be aesthetic. They should be biocompatible, non-irritant, non-toxic, insoluble in saliva and other oral fluids, which means they should be stable. They should have enough strength to withstand the force of condensation, adequate working and setting time, easy to manipulate. The coefficient of thermal expansion should be same as that of the tooth structure. They should be good thermal insulators and provide a barrier against electrical shock and chemical irritation. Low viscosity and film thickness is desirable to flow along the interfaces and into the gaps, and capable of wetting both surfaces it is binding to, be it the tooth or be it the prosthesis. Fluting agent 25 millimeters is recommended, and base 40 millimeters is recommended. So the dental cements may be classified according basically two ways, according to the and the application and use. Now the classification based on composition. So basically the zinc oxide based cements, which include zinc phosphate, zinc oxide eugenol, and zinc polycarboxylate. Then the aluminosilicate powders, which include silicate cements with phosphoric acid, and GIC with polyacrylic acid. Then miscellaneous cements, which include calcium hydroxide, resin cements, and cavity varnishes. So we will be discussing all of these cements individually, which includes again their composition, their types, their properties, their applications, advantages and disadvantages. This is a very lengthy topic and a very important one as well. And you should be familiar with all these cements by the end of the lecture. So let's look at the classification based on application or clinical use. Application, if we talk about cementation of indirect restoration, orthodontic bands and endodontic posts, they include GIC, zinc phosphate, zinc polycarboxylate and resin-based cements. As a cavity base, again GIC, zinc phosphate, zinc polycarboxylate. Cavity liners like calcium hydroxide, zinc oxide, eugenol and GIC. Pulp capping, calcium hydroxide, zinc oxide, eugenol. Then temporary filling, root canal sealers, and these are all the applications, and the classification is based upon this application. So this is a very broad classification, uh, um, and commonly you are commonly asked to basically classify according to the composition. So the classification of dental cements, let's go back again according to composition based on phosphoric acid, as we said, zinc phosphate and silicophosphate. Based on organometallic chelate compounds, zinc oxide, eugenol, ethoxybenzoic acid, calcium hydroxide, and polyalkanoates like polycarboxylate cements, GIC, and resin modified glass ionomer. So various books have classified the dental cements in various ways. Again, another classification based on use as the cementation or luting agents. You just remember the name: glass ionomer cement, resin cement, zinc silicophosphate, zinc phosphate, and zinc polyphosphate. Then the temporary or intermediate restorative materials: GIC, zinc phosphate, zinc oxide eugenol, zinc polyphosphate. High strength insulating bases. Now these include GIC, zinc phosphate, zinc oxide eugenol, and zinc polycarboxylate cement. Then the pulp capping agents. So these are calcium hydroxide and zinc oxide eugenol cements. Aesthetic restorations, so the cements that may be used as aesthetic restorations are GICs for class 3 and class 5, and silicate cements for class 3. So this is the classification according to the application. So now let's start with the first and one of the oldest cements, the zinc phosphate cements. This is a very important cement. It's still used despite being very, very old. It's been around for a very long time. You'll also be doing the mixing of the cement for your OSPI, thickness of 40 microns. So this is the classification in which the application as well as the film thickness is mentioned. So they're available as powder and liquid and capsules of pre-proportioned powder and liquid. Let's look at the manipulation of zinc phosphate. The powder and liquid are dispensed onto a cool mixing glass slab. Recommended powder liquid ratio. Now this is very important for the OSCE point of view as well as the theoretical point of view. 1.4 gram powder to zero point 0.5 ml liquid. And the very important clinical point is that the powder is divided into increments to ensure proper mixing. We do not mix it all together once as a bulk. We divide it into increments and mix it one by one. The reason behind this is to ensure proper mixing. It makes the reaction less vigorous as some amount of acid is neutralized. And an important aspect that because it's an exothermic reaction, heat is evolved, and if we do the mixing in increments, the heat is dissipated all over the slab. It isn't released all at once, so that doesn't basically interfere with the properties of the cement. Then we carry out brisk spatulation of each increment for 15 to 20 seconds. This is very important. Now the consistency or the viscosity is very important. If we want to use this cement for the luting purpose, the consistency should be stringy, and if we want to use it as a base, then it should be putty-like or highly viscous. So this is basically in your hands, basically what application you are using it for. and that is basically your mixing again depends upon that factor. Stainless steel cement spatula and clean cool glass slab are used for the mixing. The powder is added in small increments to dissipate the heat and ensure even mixing. As you can see, there are about 6 to 9 increments that we've made of the powder, and we mix each increment one by one into the liquid. So this basically shows how it's done. Brisk spatulation all over the slab is done, and then if we lift it, that makes a string-like consistency, which is in the case of E. So this is used for luting. In case of F, it is very viscous and putty-like, so it's definitely used for used as a base material. Now the important setting reactions. So as you know, in the powder there is zinc oxide, and in the liquid there is phosphoric acid. So this is basically an acid-base reaction. The phosphoric acid, it attacks the surface of the powder particles and releases the zinc ions. Aluminium, which is present, has already formed a complex with the phosphoric acid and yields a aluminophosphate gel on surface of the remaining particles. It is highly exothermic, and the setting time is about 2 to 8 minutes. The set cement is a core structure consisting primarily of the unreacted zinc oxide in the middle, embedded in an amorphous mixture of aluminophosphate. So the setting reaction is very important, and this is what it looks like. So there is an unreacted zinc oxide core surrounded by a zinc aluminophosphate matrix. Now, very important, what are the factors that increase the setting time? So, if you use a low powder liquid ratio, the mix would be thin and hence more working and setting time, but this would affect the strength and decrease it immensely. So, this is not recommended. Incremental mixing with small quantity of powder introduced into the liquid. If you like, when you do the mixing in increments, this increases the working time and setting time, and you get more control over the working time. Prolonged spatulation may increase the setting time, but the matrix is destroyed, so this is not also recommended. The best method is the cooling the glass slab. It's the most effective method, leads to retardation without affecting the strength or any other property. So if someone asks you what is the best method to increase the setting time of zinc phosphate cements, the answer is to cool the glass slab. Now the frozen slab technique is this is a basically clinical technique in which we can increase the working time and reduce the setting time of zinc phosphate. 50% increased powder liquid ratio mixing in a frozen glass slab at 21 degrees. So we use a frozen glass slab or a cool glass slab at 21 degrees. So if when multiple, if we require to uh, cement multiple castings or prosthesis, this is very effective. So we get more time to do our mixing. Excessive cement is easy to clean up, but the only drawback is that this leads to decreased compressive strength of the cement. Now, the properties of zinc phosphate, the compression strength is very good, one of the highest of all the cements, 104 to 119 megapascals. 70% of the strength is achieved in 30 minutes and maximum in 24 hours. More the powder, greater the strength. The water content, both loss or gain, reduces the strength. Tensile strength, however, is low. It is brittle. Modulus of elasticity is very good. It's 13.7 gigapascals. So it's a stiff material and resistant to elastic deformation. Other properties are that 0.06% solubility, so the solubility is low. Thick mix, less solubility. Water content, any change increases the solubility. Moisture also increases the solubility. Film thickness, the thermal film thickness is also acceptable. It is a good thermal insulator. Adhesion properties, it adheres by micromechanical bonding. pH is 2 at the time of cementation, however, it goes up to 5.5 after 24 hours. It shows moderate pulpal response. Pulp protection, for pulp protection, basically it is said to avoid thin mixes and use zinc oxide, calcium hydroxide, or cavity varnish underneath it. So the major disadvantage, as you saw, that the pH may it goes to 5.5, so it is acidic and may be pulp irritant. However, that can be overcome by applying a liner underneath or a varnish. It is brittle and it does not adhere to tooth. Chemical applications of zinc phosphate cement, temporary restoration, base, and luting. So uses permanent cement for indirect restoration, as we said, as a luting agent or a cementation agent for inlays, onlays, crowns, and bridges, uh, or orthodontic brackets, and it may be used as a high strength base, or for as a temporary restoration until the actual permanent restoration is given. It can be used for the time being. Applications. Now, the modification of zinc phosphate cements. There were several modifications done to improve or enhance the properties. Copper cements were introduced, in which, along with the zinc oxide, copper, silver, and other heavy metals were incorporated. Liquid was the same; it was phosphoric acid. Um, we achieved an extremely antimicrobial germicidal cement due to copper and silver. However, the major drawback was that it caused staining of teeth and its unesthetic black color was disliked. So that's why it was discontinued. Then the modified zinc phosphate cements. So silicophosphate cements are an example of modified zinc phosphate cements. Application type 1 cementation of fixed restoration, type 2 provisional restorative materials, and type 3 dual purpose materials. So these are basically modifications of zinc phosphate cement. Now, then came the silicate cements. Now, these were the oldest yet obsolete cements that were tooth colored. So you can say the first ever tooth colored or aesthetic cements that also showed anticariogenic properties. Anticariogenic means that it prevents caries due to the fluoride release were the silicate cements. They were composed of silica, alumina, fluorides, and calcium phosphates. Liquid was the same as zinc phosphate. It was phosphoric acid, water, and other additives. So this also showed an acid-base reaction on setting when the powder and the liquid were mixed. The properties were that it had very good compressive strength, about 130 megapascal, but highly acidic. The pH 2 of 2 can cause damage to pulp if the dentine is deficient, and it can definitely irritate the pulp. Very low solubility, so it disintegrated and discolored over time because it dissolved in saliva and oral fluids. However, fluoride release over time due to the fluoride present in its components led to its anti-cariogenic properties. It was aesthetic, so it could be used in interior restoration. However, a major contraindication was in mouth breathers because in people who basically are mouth breathers, the surface dries up and appears chalky and it disintegrates. So basically, this cement was discontinued due to these reasons, and because the better cements like glass ionomers in the market. Then the silicophosphate cements, they're a combination of zinc phosphate and silicate cements. So these came in later, contain small amounts of mercury. Composition was basically silicate glass and zinc oxide, 13 to 25% fluoride, liquid 50% phosphoric acid, 45% water, and 4 to 9% zinc, and 2% aluminum. Advantages were that it showed better toughness than zinc phosphate. It also had fluoride release and degree of translucency, lower solubility, and better bonding. However, disadvantages were the less satisfactory mixing and rheological properties, that is, the flow properties were not good, led to higher film thickness and greater potential for pulp irritation. And it was used for cementation of orthodontic bands and restoring non-white teeth. Now moving on to the zinc polycarboxylate cement. So this was the first ever cement developed with adhesive qualities. It bonded to tooth chemically, and it was also anti-cariogenic due to the fluoride release. Let's look at the composition of zinc polycarboxylate. Again, a powder and liquid. Powder contains zinc oxide, 89%, so it's the main constituent. Magnesium oxide, barium oxide, again. So the powder content is same as in phosphates. The liquid, however, contains a different acid, polyacrylate or copolymer of acrylic acid, 32 to 48%, and this basically reacts with the zinc oxide. Then other carboxylic acids such as itaconic acid or malic acid in 30 to 55% were added to control the rate of reaction. Stannous chloride adjusts the setting time and increases the strength, and also acts as the fluoride component, which basically gives it anticariogenic property. Manipulation mixed on a non-absorbent surface. The powder liquid ratio is 1.5 is to 1, and it is again mixed in increments in patting and folding motions for 30 to 60 seconds. A cool glass slab and refrigerated powder can be used to increase the working time. Again, this is the recommended method. Must be adapted to tooth before it loses its glossy appearance. So these are the basically clinical clinical considerations, and this cement is also very important from your exam point of view. Setting reaction is again is an acid-base reaction. The polyacrylic acid dissolves and reacts with the zinc oxide. Release of zinc, magnesium, and tin ions which bind to the polymer chain via the carboxylate group. So in this case, a cross-linked salt is formed as the cement sets. And before that, there is leaching out of the metallic ions, and this binds to the polymer chain with the carboxylate group. The properties of zinc carboxylate as zinc polycarboxylate compressive strength is not very high. It's around 55 to 67 megapascal. However, it's superior in terms of the tensile strength compared to zinc phosphate. pH is of the liquid is 1.7, but due to the presence of the metallic oxides in the powder, it is neutralized. It is acidic but not irritant to pulp, and quite biocompatible. Film thickness is 25 microns. Solubility in water is low but more in acids. It is radiopaque because of the core of unreacted zinc oxide. Anticariogenic because of fluoride release, and because of the setting reaction in which the metal ions are released and they bond to the carboxylate group. So there is inherent bonding to the tooth carboxyl group of the polyacrylic acid, which reacts with the calcium ions of the tooth. So this basically leads to a chemical bond with the tooth. Now the advantages and disadvantages. The advantages are definitely the chemical bonding to the tooth, the good marginal adaptation as a result, anti-cariogenic properties because of the release of chloride, and it is mildly acidic and it does not damage the pulp. Disadvantage is the low compressive strength, and the statics are poor, and solubility in oral fluids is high. Now, the applications of zinc polycarboxylate is used as a permanent cement for crowns, bridges, inlays, and onlays for orthodontic cementation, and it may be used as a high strength base. Now let's talk about the cavity varnishes. So, as we saw in the previous slides, it's a solution of one or more resins, which is when applied to the cavity walls, evaporates because of the presence of a volatile solvent, leaving a thin resin film that serves as a barrier between restoration and the dentinal tubules. So basically, its main function is to seal the dentinal tubules. So in doing so, it prevents post-operative sensitivity from galvanic shock, minimizes the penetration of certain acids from different cements like zinc phosphate, and in case of amalgam, it prevents diffusion of corrosion products from it into the dentine. So it has a protective basically function. They are usually applied in a film thickness of 2 to 5 microns and could be applied to all prepared cavities on both the enamel and dentine. Protective coating and barrier to leakage seals the dentinal tubules and reduces leakage but provides no thermal insulation or any kind of mechanical protection. Film thickness is 25 microns. Solubility in water is low but more in acids. It is radiopaque because of the core of unreacted zinc oxide. Anticariogenic because of fluoride release, and because of the setting reaction in which the metal ions are released and they bond to the carboxylate group. So there is inherent bonding. So the purpose of a cathetic liner or varnish is to serve as a physical barrier to ingress of bacteria or bacterial byproducts, to provide therapeutic effects such as antibacterial, anticariogenic, or purple anodyne effect, provide a barrier for protection of pulp from residual reactants diffusing out of a restoration, and prevent oral fluids that may penetrate leaky restoration from reaching the pulp to the dead teeth. Again, to reduce the leakage around the margins and prevent penetration of corrosive products into the teeth. A very important fact is that varnish should never be used under composite restoration because it interferes with the setting reaction, or the glass ionomer restoration because it prevents fluoride use. So these are two restorations underneath which varnishes are contraindicated, which are the composite restorations and glass ionomer restoration, because it interferes with the setting reaction, and in case of glass ionomer, it prevents fluoride release. Let's move on to the glass ionomer cements. These are very important cements and have multiple uses and applications in dentistry. So, this was a tooth-colored material introduced by Wilson and Kent in 1972. We could say it was a combination of the properties of polycarboxylate cements and silicate cements. Uh, so, they were tooth-colored anticariogenic restorative materials, combined the properties of silicate and polycarboxylate cements. Minimal cavity preparation was required because it also bonded adhesively or by chemical means to the tooth structure. So, basically, why glass ionomer cement? Because the powder is glass and the setting reaction and adhesive bonding to tooth is due to ionic bond. As you can see from these pictures, it is bonding directly to the tooth surface, the calcium and the phosphate ions by forming bonds with the calcium and phosphate ions in the tooth surface. So let's look at the classification of PICs. They may be classified according to the traditional glass ionomers may be classified according to the types. So type 1 is the luting cement, type 2A is the static restorative cement, and type 2B is the reinforced restorative cement. Then type 3 is basically the liner and basis. So this is based on the application. Then we have metal modified glass ionomers, miracle mix and cermet cements, then the hybrid glass ionomer or the resin modified glass ionomer, which contain composite resins in which fillers are substituted with glass ionomer, and then the pre-cured glass is blended into one. So these are the different. This is basically the classification of GIC. And then if we classified it according to its applications, so you have type 1, which is used for luting, type 2 for restoration, type 2A restorative aesthetic, type 2B restorative reinforced, then type 3 for liner and bases, type 4 for fissure sealants, type 5 for orthodontic cements, and type 6 for core builder. So they can be classified both ways. Let's look at the composition of GIC. Again, you have a powder and a liquid. The powder contains various various metals like silica, basically silicon dioxide, which is about present in 42%, alumina 28%, aluminum chloride 1.6%, calcium fluoride 15.7, sodium chloride 9.3%, aluminium phosphate 3.8%. Then barium and strontium oxide may be added to give a radio opacity. The liquid contains polyacrylic acid or a copolymer of acrylic acid in 40 to 50%, and this basically reacts with the silicon oxide and the aluminium oxide. Uh, and then other carboxylic acids such as itaconic acid or malic acid, this controls the rate of reaction, and tartaric acid as well, which also contains the rate of reaction. This is the composition of glass ionomer cement. It is also known as an acid-soluble calcium fluoroaluminose silicate glass. So the powder basically contains an ion-leachable fluoroaluminosilicate glass, dried polyacid in powder form, and it is made radiopaque by adding strontium or lanthanum or barium sulfate. And the particle size basically for restorative material should be less than 45 microns, and for luting purpose the particle size is as fine as 15 microns. So both of these restorative GICs and luting GICs are available separately, and their particle sizes are also different. The liquid of the GIC contains this aqueous solution of polyacrylic acid, Alone or a copolymer of acrylic acid with itaconic or malic acid. Water and tartaric acid are also present. They control the rate of reaction. Then other constituents are the phosphates and fluorides. Now the function of these are to decrease the glass fusion temperature, improve handling properties, increase the strength. Lanthanum and strontium, they give it radioopacity. And then all the fluorides, they impart the anticariogenic property, which is a very important property or quality of glass ionomer cements. So the liquid, the polyacrylic acid copolymer with itaconic acid and malic acid basically reacts with the fluoroaluminosilicate glass. Tartaric acid improves handling characteristics, and as we mentioned, water is the medium of reaction and hydrates the reaction product. Tartaric acid is very important, and this question has been asked many times in your exam. So the function is it is basically an additive in glass ionomer cements, but it has various functions. It improves the handling characteristics, increases the working time but decreases the setting time, aids in the complex formation between the polyacid and aluminium ion, and it may show to increase the compressive strength. And then the other acid copolymers in GIC, what is their function? They increase the reactivity of the liquid, decrease the viscosity, and reduce their tendency for gelation. Tartaric acid, as we mentioned, improves handling characteristics, increases working time, decreases setting time, and increases the strength. So these acid copolymers, they have these various functions, and they're just as important as the main acid, which is the polyacrylic acid. Composition of GIC. Now the role of water. So water has two roles during the reaction. Because it's an acid based reaction, it acts as an ionizing medium, then slowly hydrates the polymer chains or the cross-link matrix. After hardening, the fresh cement is extremely prone to cracking and glazing, and this may be due to drying or dehydration of the water. So more intake of water will result in dissolution of the chains and degrade the physical properties. So that is why the role of water is very critical when we are carrying out the glass ionomer cement filling or mixing. It should be manipulated in an isolated environment with complete moisture control and isolation. Saliva or water should not contact or contaminate the filling. Otherwise, it can result in degradation of the properties or dissolution of the chains. So how is the moisture sensitivity controlled? Well, it should be protected during the first hour from moisture contamination. We should manipulate it in an isolated environment, preferably with a rubber dam and good suction and cotton rolls with an environment free from blood or saliva. And cement should be properly covered or sealed after placement. So after we've done the filling with the glass ionomer cement, we apply a varnish on the surface of the restoration or a bonding agent or Fisher sealant so that it does not dehydrate or desiccate or lose or basically take in. Now the factors affecting the rate of setting of GIC. Firstly, with respect to the powder, the high alumina silica ratio increases the reactivity of glass and decreases the working time. Using a freeze-dried polyacid basically dissolves to form liquid acid, and this is followed by acid-base reaction. This increases the working time. So if we use a freeze-dried polyacid powder instead of the conventional powder, this can increase the working time. Effect of tartaric acid, as mentioned in the previous slides, it because it makes the complex with aluminium, so it increases the working time. Tartaric acid prevents unwinding and ionization of the polyacid chains initially, so this also basically increases the working time and decreases the setting time. So the other factors are basically the fineness of the particle size of the glass powder. So the finer the particle size, higher is the setting rate and lower is the working time. And then increase in temperature, obviously the faster the setting of the cement, lower the working time. These are all the factors that basically affect the setting time of glass ionomer cement. Role of fluoride is very important. Fluoride, because it forms metal complexes, retards the binding of cation to anion sites on the polyacrylate chain, delays gelation and prolongs the working time. So causes release of hydrogen, acidity of paste increases, delays the pH dependent deletion. So role of fluoride is quite critical. Let's just look at the manipulation very briefly. So the first step, isolation, because moisture control is very important. Proportioning and mixing of the material. Uh, we'll talk about this in detail in the practical demonstrations. Excess cement must be removed at the appropriate time. Protection of the restorative surface, and we place either varnish or resin cement on top of the glass ionomer cement because it is sensitive for the first 24 hours, and finishing is always done after 24 hours. So basically this shows how it's done. So 1 level scoop of powder and 2 drops of liquid. Hold the bottle vertically, and the polymer paper mixing pad or a glass slab may be. They're different consistency for again depending upon the application. For type 1 luting, when we're mixing it, the consistency should be string like, and as you can see from the picture, the string should be able to lift up to 3 to 4 millimeters from the slab. For type 2, string 1 centimeter and it should be glossy. Type 3, as a lining for amalgam, the ratio powder liquid ratio should be 1.5 is to 1, and 3 to 4 centimeters string should be formed. And in case of a base, the powder liquid ratio is higher. It is 3 is to 1 because it has to be more viscous and thick. And the string should be only 1 to 1.5 centimeters up from the slab. Now we'll move on to the setting chemistry of GIC. So this is basically just showing how the polyacrylic acid attacks the glass component, the powder component, and how the different cations are released, and as well as the fluoride ions. And then finally cross-linking of the polyacid with the cations, giving us a matrix and unreacted glass core. So, if we'll talk about the chemistry of setting, there are 3 stages basically. The step 1 is dissolution, then precipitation of salts, dilation and hardening, which is step 2, and then hydration of salts, which is step 3. So, the first step, which is dissolution, so this happens when the powder and liquid acid attack on the glass surface, leading to diffusion. Adhesion between glass particle and matrix takes place. 20 to 30% decomposition and leaching of ions, leading to the formation of a cement salt. So this is basically, as the name suggests, dissolution, where all uh, the the different ions they move out of the powder due to the attack by the liquid acid. Then the precipitation of salts, gelation or hardening. So now all the ions that have moved out, there is cross-linking of the calcium ions to the polyanions via the carboxylate group. Precipitation involves the fluoride and the phosphate ions forming insoluble salts and complexed with the sodium ions. In gelation, sodium ions involved as the pH raises and salt form is converted into gel form. So basically it's going towards hardening, which occurs due to cross-linking between the chains, leading to a hardening and setting. And the final step, or the hydration, this is a very important step, and this is due to the presence of water. This is where the role of water comes in. It is an important constituent of the liquid and it is involved in setting. It causes additional salts to form, hence leading to the final setting. But at the stage, if water is lost by dehydration, this can basically disrupt the reaction, leading to loss of translucency, and that is why we apply either Vaseline or a varnish or a resin cement over the glass ionomer cement restoration after it sets. So basically, this is a diagrammatic representation of the setting reaction, how the ions are moving and cross-linking and forming basically a glass core and a silica gel. The conversion, basically how it's taking place, polysalts are being formed. So the final setting takes place when metal cation salts bridge form with the carboxylate anions, resulting in formation and hardening. And final setting basically takes place after 1 to 3 days when aluminium replaces the calcium ions, and this results in an aluminium cross-linked polymer gel. Let's look at the summary of the setting reaction. So first of all, there is dissolution and breakdown of the glass particles, precipitation and migration of ions into the aqueous medium, sodium and calcium ions cross-link with the tooth structure and polyacrylic acid, hydration where the water comes in and strengthens the final matrix, and the last step, which is maturation, when after 1 to 3 days the aluminium replaces the calcium and forms a crosslink matrix. So this is just a summary. You should know the detail, and it's a very important setting reaction. Now let's look at the advantages and disadvantages of GIC. The advantages is the inherent adhesion to the tooth surface, the good marginal seal, anticariogenic properties because of release of fluoride. It is very biocompatible and it requires minimal cavity preparation. However, the disadvantages are it has low fracture resistance, low wear resistance. So the mechanical strength isn't very, the mechanical properties aren't very good, and it is water sensitive during the setting phase, less aesthetic compared to composites, and it is susceptible to erosion. If you look at the properties, it is very biocompatible. Coefficient of thermal expansion is close to tooth. Again, but again susceptible to acid erosion. Its appearance, it is tooth colored and it has low solubility and it can undergo disintegration. So if we'll talk about tooth adhesion or the fact that it creates a chemical bond with tooth, so basically the polyacid molecules chelate with calcium at the tooth surface, and this forms an interfacial calcium polyalkanoate salt, and that is why we say that GIC bonds chemically to the tooth. So this is the principle of adhesion or bonding to the tooth structure. If we go into detail, so the outer layer of the apatite on tooth becomes solubilized in the presence of acid. Re-precipitation of complex mixture of calcium phosphate and calcium salts of polyacids are deposited onto the tooth surface. And that is why an ionic bond with hydroxyapatite in dentine is formed. So basically, it's not only bonding to enamel; it is also bonding to the dentine. Now, if we discuss the anticariogenic properties, this is due to the fluoride release at the time of mixing, and it lies within the matrix, which serves as a reservoir. So the fluoride release keeps taking place over a period of time. Early release is from the matrix. Long-term slow release is by diffusion from particles. And the rapid release is basically by the initial dissolution when the acid attacks the powder, and the long-term release is basically from the cement matrix. So these are the two very important properties, adhesion to tooth and the anticariogenicity due to fluoride release. If you look at the mechanical properties, it doesn't have good strength. It has low abrasion resistance, although good compressive strength, but low flexural strength, and it is highly brittle. Modulus of elasticity is only half that of zinc phosphate. It is less stiff and more susceptible to elastic deformation. And if we want to support or cement an all ceramic crown, it is less desirable than zinc phosphate because greater tensile stresses could develop in the crown that is supported by GIC under occlusal loading, and the modulus of elasticity, because it's low, so it cannot resist the basically the tensile stresses and the forces that could develop underneath the crown, and it is more vulnerable to wear than at the classification of glass ionomers according to application. They may be divided into type 1, type 2, and type 3. Type 1 are the luting and bonding materials. Type 2 are restorative, are divided into two types. Type 2 1, type 2 2. Type 2 1 is the restorative aesthetic, self-cure or auto-cured and resin modified. Type 2 2 are the restorative materials, and type 3 are used for lining or base cements. Type 1, the luting and bonding material, used for cementation of inlays, crown, bridges, and orthodontic appliances. Powder liquid ratio is usually 1.5:1, but if we use freeze dried polyacids, then it is about 3.8:1. Fast setting cement and shows early basically uh, resistance to water uptake, and it has moderate strength. Restorative, when the type 2 1 restorative aesthetic, autocured, and resin modified. For areas where there is minimum occlusal load bearing, static restorations basically, high powder liquid 3 is to 1, but in case of the freeze dried polyacid, the ratio is 6.8 is to 1, shows good translucency and shade range, long setting time, so remains susceptible to water loss again. Loss in uptake for about 24 hours after replacement is seen. Then the type 3 lining or base cements. For lining material under restorative materials, the powder liquid ratio is about 1.5 is to 1. So they have good flow properties and low viscosity. And if used as a base or dentine substitute, the ratio goes up to 3.1, 3 is to 1 or 6.8 is to 1. They can be autocured or resin modified, and they're also radiopaque. Because of the increased powder content, the physical properties are also better. So now moving to the clinical applications or indications of GIC. So they're commonly used as deciduous or pediatric fillings because they're temporary in nature. However, they may be used for permanent class 3 and class 5 fillings where the masticatory stresses are less. They can be used for ART, which is atraumatic restorative treatment. Now, these are basically clinical procedures in which hand instruments are used to excavate or remove the caries, and the filling is done with an adhesive material. In this case, usually it is GIC, and it may be used as a luting ceramic for it may be used for luting ceramic restorations, used for luting metallic restorations like inlays, onlays, crowns, and bridges, used for luting orthodontic brackets and bands, used as a lining or base cement under a restoration, used to treat avulsed teeth with splinting. It can be used to treat dentine hypersensitivity, for core buildups, to treat the eroded areas, used as pits and fissure sealants, which are also basically preventive. This is a preventive procedure in which is done to seal the pits and fissures of newly erupted posteriors, and it may be used in the sandwich technique under composite restoration. So, what is the sandwich technique? This is basically a procedure in which the filling of a composite resin is done with a glass ionomer cement lining, and that is why it's called a sandwich technique, because they basically two materials which are placed on the tooth. So the procedure is that the cavity preparation and tooth conditioning etching is done. We placed type 3 GIC as a liner, then etch the enamel in GIC with orthophosphoric acid for 15 seconds. We apply the enamel bonding agent, and then we finally place the composite and cure it. So this diagram basically represents what it looks like. And as you can see, why it is called the sandwich technique. The adhesive characteristics of GIC is combined with the good aesthetics and durability of composites. So these are the two very important properties: adhesion to tooth and the anticariogenicity due to fluoride release. If you look at the mechanical properties, it doesn't have good strength. It has low abrasion resistance, although good compressive strength, but low flexural strength, and it is highly brittle. Metal modified GICs. They were introduced to improve the strength, fracture toughness, and wear resistance, which was the main drawback of conventional glass ionomer cements. And basically, there are two types: the silver alloy admix, also known as miracle mix. And this basically, what we do is we simply mix the silver alloy of the amalgam particles with GIC powder, and we use the liquid of the GIC powder. So this is called miracle mix. And cermets, which are basically already preformed cements in which the bonding of silver particle to glass ionomer is done by fusion through high temperature sintering. So these are the two types of metal modified GICs. Glass ionomers have been modified by addition of filler particles to improve strength, fracture toughness, and resistance to wear. So this is basically just a repetition. Basically, the physical properties, if we look at them compared to the conventional glass ionomer cement, strength is about the same, the fracture toughness is the same, only the wear resistance is increased slightly, and fluoride release, however, was reduced with some Summit, was same or slightly increased with Admix. So there wasn't a very considerable improvement in the properties, just the wear resistance showed a slight increase. Now, indications of metal modified in class 1 cavities in the primary or deciduous teeth, core buildup material, lining of class 2 amalgam restorations, root caps or teeth under overdenture, and as a preventive restoration. Contraindicated in the interior restoration because of obviously it's basically silver or grey colored. Not exactly silver, but more of a grayish tinge. And it is contraindicated in areas of high occlusal loading. Advantage is ease of placement and has addition to tooth and is anticariogenic. Crown cutting can be done immediately and it has better wear resistance. Disadvantages, however, is that aesthetically it's poor, it has a rough surface, and tooth may undergo discoloration. So, if we compare the metal for modified and conventional GIC, so there was no significant improvement in the mechanical strength, just a slight increase in the wear resistance. As mentioned, the fluoride release was reduced in CERMET and same or slightly increased with admix. And then finally, the aesthetics were basically uh, aesthetics were poor due to the metallic color. Now let's move on to the resin modified glass ionomer cements. They're also known as hybrid ionomers. So basically, if you look at the composition, the glass powder in resin modified glass ionomer is the ion leachable calcium fluoroaluminosilicate glass, which is the same as the conventional glass ionomer. However, the the additional component is an initiator. That is why it is known as a resin modified glass ionomer. Is the presence of an initiator. It may be a light or chemical activated, and then the liquid along with water and polyacrylic acid, there is a methacrylate and HEMA or bis-GMA. So this is the resin component of the resin modified glass ionomer, which is present in the liquid, and in the powder we have an initiator. So let's look at the properties. Compressive strength is 150 megapascal, tensile strength 25 to 35 megapascal, film thickness 20 microns. So the advantage of the resin modified glass ionomer is that this has a combination of the strength and insolubility of the resin composite and the fluoride release of GIC. So it can be said as a hybrid of glass ionomer and composite. If you look at the setting reaction, so basically two kinds of setting reactions take place. First is the photopolymerization of HEMA, because the initiator is present and the resin monomer is present, so their initial setting is by polymerization, and then subsequent acid base reaction takes place because of the presence of the aluminosilicate glass and the polyacrylic acid in the liquid. So along with the photoinitiator, at times the chemical initiator is present, and these resin modified glass ionomers are known as dual cured. Those two kinds of curing, chemical and light curing, are taking place side by side. So if we compare the properties of the resin modified glass ionomer and conventional GICs, we observe that the tensile strength in compressive and flexural strength is superior. Then the conventional GIC, higher bond strength to tooth, susceptible to additional water uptake, so this may lead to expansion, susceptible to dehydration, crazing, cracking. It shows polymerization shrinkage because obviously there is a resin matrix present and polymerization is taking place, and the setting time is shorter. But the advantage is that finishing can be done immediately, unlike GIC, which takes about 24 hours for the maturation stage to take place. This sets immediately, and finishing can be done immediately. Then let's talk about the compomers or the poly or acid modified resin composites. So they have the fluoride releasing capability of GIC, durability of composites. They're similar to resin modified, however, there are many differences, and it is important that you know the difference between compomer and resin modified glass ionomers. So compomers are also known as polyacid modified composites, and they are made by incorporating glass particles of GIC. Then there is a water-free polyacid liquid monomer with appropriate initiator. Properties are distinctively different from those of the composites in GIC. So integration of fluoride releasing capability of GIC and the durability of composites led to the formation of let's look at the composition. Cyanidized fluoroaluminosilicate glass powder and polyacid modified monomer without water. Now the important thing is like unlike the conventional composites and resin modified glass ionomers, there is no water present in the liquid. There's just a polyacid modified monomer. So this table also is also basically telling about the ingredients or the composition of the modified composites and the resin modified glass ionomers. So as you can see that the active ingredients in the compomers is fluoroaluminosilicate glass and a methacrylate acid resin which is acid modified without water. Then we have activators, initiators, stabilizers. In the resin modified glass ionomer, we have the same fluoroaluminosilicate glass, the methacrylate, polyacid, and HEMA. Water is present in this case, and activators, initiators, stabilizers. So the main basic difference is the presence of the water, is the absence of water in compomers and the presence of water in resin modified glass ionomers. So if we compare the compomers with GIC and resin modified, lesser and slower fluoride release, bond strength is same as that of GIC due to the use of dentine bonding agents. So in case of compomers, there is no bonding to the tooth directly. We need to apply a dentine bonding agent, and the fluoride release is even lesser than that of the resin modified and the conventional glass ion. Composer contains no water. First of all, it is hydrophobic. Polymerization takes place. There is no acid-base reaction. Lacks the ability to bond to tooth and requires a bonding agent. So these are the basic main key features of compomers. Uh, Releases fluoride, so that is a similarity with glass ionomer. However, poor marginal integrity retention and undergoes occlusal wear. So let's look at the properties of the three: the conventional glass ionomer, resin modified glass ionomer, and the resin modified glass ionomer, compomer, and composites. So basically, if we're moving from the glass ionomers to the composite, the fluoride releases decreases, the strength increases, going from the conventional glass ionomer to composite, the static increases, and wear resistance also increases. So the only thing that decreases basically is the fluoride release, which means that the conventional glass ionomers have the highest fluoride release, followed by the resin modified glass ionomers, then the compomers, and least in composites. Now, the recent advances of glass ionomers, currently there are basically GICs have been incorporated with fibers like alumina fibers into the glass powder to improve its flexural strength, and then silicon oxide ceramic fibers have been added. So there is increased depth of cure as light conduction and penetration is enhanced. Polymerization shrinkage is reduced and resin is confined within the chamber. So these are different basically advancements that have been taking place in these. Then you have proline containing glass ionomers, it have better surface hardness properties. Um, this is basically a very biocompatible material, so it has been shown to act as a bone cement as well. So you don't have to really go into the detail of these recent advances, just for general knowledge sake. Then gyomers we discussed earlier. So the fluoroaluminosilicate is reacted with polyalkanoic acid before, and this pre-reacted glass is then mixed within the resin. So this is called a pre-reacted glass ionomer technology. We discussed the dental cement timeline earlier. So now let's very briefly discuss the properties of all the cements we've discussed in this topic. We'll start off by looking at the advantages. So zinc phosphate, zinc polycarboxylate, glass ionomer cement, and resin modified glass ionomer. If we start with zinc phosphate, we can appreciate that it has the best compressive strength, adequate film thickness, reasonable working time, and it can be used in regions of high masticatory stresses and long span prosthesis. Zinc carboxylate, polycarboxylate is very biocompatible, pseudo-plastic. It has favorable tensile strength and it undergoes chemical bonding. So this is a major advantage with respect to zinc polycarboxylate. Glass ionomer, it is anticariogenic. It has the ability to absorb fluoride, and this is called fluoride recharge because to make up for the fluoride loss, it can absorb fluoride from the oral environment, and if there is a deficiency of fluoride or there is a need of remineralization, it can also release that fluoride. So this is called fluoride recharge. Coefficient of thermal expansion is similar to tooth. It is translucent. It has adequate resistance to acid dissolution, low film thickness and constant viscosity, and it also undergoes chemical bonding or chemical adhesion to the tooth. Now, resin modified glass ionomers, they have improved compressive strength, diametral tensile strength, and flexural strength. They are less sensitive to moisture contamination compared to glass ionomers. Less soluble than the GICs, easy to manipulate, low film thickness. Fluoride release, it is said that it is similar to conventional GICs, however, it is a bit less, and high bond strength to moisture. Similarly, let's look at the disadvantages. So starting with zinc phosphate, it is highly acidic, low tensile strength, does not undergo any kind of chemical bonding. It has it is basically soluble in oral fluids and does not have any kind of antibacterial properties. Zinc polycarboxylate, it has no resistance to acid dissolution, so manipulation is critical, and there is a rapid rise in the film thickness earlier that may interfere with proper seating of casting or prosthesis. GIC initial slow setting, sensitivity to moisture is a major concern. Modulus of elasticity is lower if we compare it with zinc phosphate. Then there have been reports of post-cementation sensitivity and insufficient wear resistance. Now, looking at the resin modified glass ionomers, along with the advantages, there's certain disadvantages like polymerization shrinkage, more water absorption because of the presence of HEMA. HEMA basically causes water absorption. Rarely may elicit an allergic response due to free monomer, and the cement bulk is very hard and difficult to remove. So these are both the advantages and disadvantages of the cements we have discussed so far. We still have three other cements left: zinc oxide eugenol, calcium hydroxide, and resin cements, which we will be discussing later on. So this table is basically a total basically summary and comparison of properties of all the cements, including zinc oxide eugenol and calcium hydroxide. I think your understanding will be better when we study those cements as well. So this has all the different properties. So I hope that the cements are clear, and if there are any questions, please feel free to ask me. Thank you so much for listening. End of our lecture, which was of the dental cements, and we covered basically zinc phosphate cements, silicate cements, zinc polycarboxylate cements, and then GICs and all the modifications in the GIC. Thank you so much for listening.